Hey everybody, it's Peggy Hasenauer. This is part two of How Are You, Lou? And we are with Dr. Philipson today. Hi, Dr. Philipson. How are you?
Hi, everyone. How are you hanging in?
I'm sure. I'm sure. We had some great interest from the last video we did, talking really about you and how you're doing in the context of seeing patients, doing clinical research, and then just more about you. What are you eating? Where are you riding your bike? How are you doing? But today I wanted to talk a little bit about this sort of concept of phase three that we've been hearing about on the news and what that looks like in Illinois and particularly in Chicago. And as we're approaching June 1, what are some changes, sort of general changes that we're going to see maybe on campus that may affect some of our patients? And what are some of the upsides of moving to the next phase, if you will, for our patients?
Right. Well, it's been a long haul. I think what we're seeing is that there's a big uptick in things in mental health issues amongst all of us. So even the people who are still functional, there's an increase in anxiety and depression. And part of what we've been doing clinically with our health and wellness program is to try to uh, reach out to folks who could use someone to talk to. It's part of the program. You know, you've helped with so much over the years, and so we're trying to make sure that people know about that. And they've been available. They're also doing sort of virtual interactions. Sometimes just telling folks what's available. Sometimes it's actually doing a session in a way,
Hmm.
so far as that's possible over the internet. So we're slowly trying to think about how we get back to business. So the upsides have been exploring telemedicine, understanding how to bring people in. Uh, I've been telling people that I've never seen so many folks exactly on time with so few people not being able to make a visit. That's been remarkable. And some of us, I've seen maybe 35 people a week that way, and it's been a positive experience for everyone. Some of my folks, some of my friends around the country also report similar experiences that diabetes lends itself to telemedicine once you get over the hump. So you need to be able to have people learn how to download their devices, send them to us. And so some of these visits are entirely about how to do that. And that's working. So we're very excited about that. It's exposed the digital divide. If you're not savvy about devices, how do we do this? So we have to then be nimble. If people can't log on to a video visit, we have to make phone calls. There's other ways of using smartphones to do a visit. So we're doing all that. And on the other hand, now we're starting to try to think about opening the place up. So there are in-person visits going on right now. Uh, so you can be seen in person, and podiatry at the diabetes center never stopped. So Dr. Zamuda, Dr. Lance, if you had a foot problem, they would see you and frequently. So that was in person and necessary. Other clinics also, the cancer clinics, the dermatology clinics, some of the surgical clinics, cancer clinics, they continue to operate at some, reduced level usually. For the
So,
diabetes
so my
clinic,
under so my understanding
okay,
then is that our diabetes clinic will be opening uh, in a sort of a more robust capacity, with, of course, fewer patients being seen and being very thoughtful about social distancing. But that may occur as early as next week. Is that correct?
that's right. So some of the doctors are already having a limited schedule for people to be seen in person, uh, and so that's it's a work in progress. How do we do the elevators? How do we do
Sure.
the waiting rooms? How do we clean rooms between visits? How do we talk to each other wearing cloth masks? So all of those things are being worked out and really starting today and tomorrow with some of the doctors. I probably won't do that until into June sometime, but it is going to happen.
Okay, that's fantastic, and I think that's good for folks to know, is that your experience with virtual visits has been great. I think it's been great for our patients, and that it will continue. So as we move forward, it sounds like we're going to do some combination of virtual visits and in-person visits, depending on the needs of the patients, and depending on their ability to be seen.
That's right. So we're trying. So when I was talking to one of our colleagues, Dr. Thomas, for example, this morning, we're very concerned that frail people, people at higher risk, people with other autoimmune diseases, or the elderly, and we don't
Right.
want to force them to come to clinic prematurely. So we're going to try to figure out how to make sure we do the best and safest thing for everyone. And that'll, as you say, that'll be some combination of in-person visits and video visits, which we hope will continue indefinitely. Some of that depends on the insurance company. So,
Sure.
thing that happened was the people who run Medicare decided that they would cover the visits, and that opened the gates right there. So then all the other insurers have to follow suit. So if they continue to do this, since it's not going away, then that'll be great. I think
That
what
would
we're
be incredible.
yeah. So what we're worried about, of course, is whether there'll be an uptick. So I think for the
Sure.
summer, we're hoping to get all this going and to figure out like the new reality. But then what's going to happen, August, September, October. So I think just like anything else in life, you hope for the best and you have plans, A, B, and C to pick up on various sorts of issues. Um, for me personally, I'm also now working on doing visits outside my usual days. So those of you who know who are my patients, my clinic day is all day Monday and traditionally half a day Thursday. I did that some years ago. But now I'm seeing patients like a few hours on Tuesday, a few hours on Wednesday, maybe Friday morning, and maybe Wednesday night or Sunday afternoon. So I think this is something that's new, and this is the next big push is to figure out how to do these visits at very short notice. So we're open for business. We want to see new patients. We can do this. Our return patients could be seen frequently. I think one of the big issues is to see people more frequently. So we can do, 15-minute visits and do it every couple of weeks if there is an issue. So those
And
are all.
I think you bring up some really valid points about trying to have more concentrated visits and more frequent visits. And I think this leads us to kind of the other topic I wanted to talk to you about. In the context of these visits, we can really hone in on what opportunities are available to our patients from a clinical research standpoint at the university. You and I were just recently on a research call, and we are sort of actively moving on anywhere between 6 and 10 protocols, depending on how you look at it. And I think the value of us being able to concentrate on research management is that perhaps we can really think about matching patients as they'd like to a study that might best fit them. So where are we at with some of the clinical research that you're working on, Dr. Philipson? We've got a
Oh,
nice portfolio, but what does it
yeah.
look like now?
Well, a lot of it is on hold. There's no doubt about that. I think
Hmm.
what we're thinking about, I mean, one grant that I'm writing right now is really based on what's the future look like? How do we do research with patients about diabetes or either type 1 or type 2 or other without actually having people come in. So this is a new world. Is what can we do virtually? What can we do
Sure.
over the internet? How do we make portals that people can log on, enter their data, and download things like blood pressure, their weight, their blood sugars, or various devices? So I'll, I think you'll, we can talk about some of the we're not talking all about the 8 or 9 studies that are going on, but I think about them in two halves basically. So one is our genetic studies. So those include atypical diabetes, which are going on. Some people have known our research manager Lisa Letourneau, who's been running the monogenic study with our colleagues Dr. Greeley and Dr. Naylor in particular. Uh, those studies are national. So a lot of that involves getting consents and talking to people this way all over the country, sometimes outside of the country, and that continues. The limitation is that we're not getting the blood samples or the saliva samples we need to do the genetics. So as the buildings open up and we can start getting shipments and doing some of the details, we will be revving that up, but we're still staying in touch with all those people. The big grant that's new is something called Radiant. So that's also a national study that now is weirdly in its entering its third year, but we have yet to recruit a single subject because it's been a 2-year planning thing in centers really all over the country. So that's been slow and difficult to get a very detailed, large protocol, but we're also looking for unusual forms of diabetes that are not type 1 or type 2. So that study may start rolling out because, again, so much of that will be this sort of interaction. Talk to people, they write to us, they say, my doctors don't understand what kind of diabetes I have, and we'll go from there. So those are two studies that are large and ongoing and basically unique to our group or that we're leaders of. And then
So
there's
so
good
oh,
5 or
so I
6
was just
other
I would
studies. But
oh, so I was going to ask you a question about that. Um, so we have two sort of major so we have two major studies that we're doing, and both involve, for lack of a better term, weird forms of diabetes. So the message we're trying to send out today is if you have a weird form of diabetes, you've never quite fit into the type 1 or the type 2 category, or maybe you got diabetes when you were pregnant and then it went away and maybe it came back, or maybe you were diagnosed at a very late age with type 1. Um, we want to hear from you, especially if you have a family history, right?
absolutely. And even so, either way. So now we're getting more involved in a new sort of idea, which is um, we're calling it monogenic type 1. So these are
Oh,
people who
interesting.
have really autoimmune type 1 diabetes, often with positive antibodies, but maybe there's multiple people in the family, multiple
Hmm.
generations, or people with multiple kinds of autoimmunity. So it's not unusual to have type 1 diabetes and thyroid disease, type 1 and celiac. But if you have type 1 diabetes and thyroid disease, celiac disease, ulcerative colitis, maybe then your sister has something else, unfortunately, maybe multiple sclerosis or rheumatoid arthritis, and your mom has thyroid disease, that's a family that we need now to start looking at harder than ever. And so we're
Right.
working with groups, especially in San Francisco, at University of California in San Francisco, to try to uncover more of that. There's funding we've been getting from the Helmsley Trust to do some of that research, and that's been extremely interesting in some of the people we've looked at so far. So yeah, so all of that is done just like this. We can get blood or saliva samples mailed to the right labs. We do the sequencing, we collect histories, and then we go back and we can tell people or their doctors ideally, if we found anything. So that's a difficult thing, and an expanding idea. Returning results is a big issue, but those are really exciting areas. So yeah, if your doctor doesn't know what you have, or they scratch their head every time they see you,
Give us a
we
call.
right, we want to hear from you.
Send us an email. And so we've got several other studies too. And I think the basic message, if I'm not mistaken, is that we have some studies for new onset type 1. We have some studies to try to understand people at various stages of their diabetes care and management with our partners in primary care. Um, and there's a few studies that we're trying to get up and running. What's one that you're really excited about once we get it up and running?
Well, one of the more interesting studies is run by Prevention Bio. So this is a multi-center study from a company, which is that really, if if everything can be done, it will tell us whether or not there's a potential new treatment for new onset type 1 diabetes, which there never has been. So this is based on a drug that was, in fact, invented at the University of Chicago almost 30 years ago by our friends Dr. Kevin Herold, who's now at Yale, and Dr. Bluestone in San Francisco, and a few other people. And so this drug has now been studied multiple times in multiple people over the last 20 years. Uh, and it was uncertain whether it could really prevent or delay type 1 diabetes. But the most recent study, which was published last summer, suggested that you could identify a group of folks who are most eligible, and mostly those are young people who have onset very soon. So the problem with the study is you have to identify people right away, and then you have to then with everything else, it's sort of oh my God, I have type 1 diabetes, and then we say yes, by the way, here's a research study we want you to be involved in, and these are the things you have to do. And that's a hard study because it involves giving the drug every day for 12 days in a row. So you have to come to one of the centers around the country. But as far as excitement, that study will allow the company to determine whether this will be standard of care. So what we call a stage 3 study. So it's beyond safety. We know that the drug has some side effects, but generally speaking, they can be managed. And relative to having type 1 diabetes for your whole lifetime, it could be a good deal. So
Absolutely.
that's called Prevention Bio is the name of the company, and teplizumab is the name of the drug. It has to be given intravenously, so that's part of the problem right now. Maybe one day something else will happen. So that's
So
one
if
of the
some
more
so,
exciting studies.
so if that's a great point. So if there are individuals that are newly diagnosed, uh, between what ages,
Well, it's
roughly?
young people, so between I believe it's yeah. So now I'm on the spot. So it's either between 6 and 18 or 8 and 18. So
Correct.
it
Yeah.
was for non-adult children, and that also makes it difficult. So then the parents obviously have to help decide for the children whether they're going to participate in this
But
trial.
they can check in with us and learn more, right? So if folks have been
Absolutely.
diagnosed within the last 60 days, children in particular,
Yeah, it's even
contact
less than
us.
60 days. So let me be clear about that. So this is 6 weeks. So it's within 40 days we have to start the trial. So that's really
It's a
hard
tight window.
to do. So we have to really start talking to people within a week or two of making the diagnosis and then explain everything to do with that study. So, if that's what you find that situation, we certainly want to hear from you.
Fantastic. That's great. Dr. Philipson, any other updates about what we can expect on the COVID-19 and diabetes front? You've had a fantastic group that you've really put together in the Chicago area. Can you tell us a little more about this group of professionals that's getting on calls periodically? Tell us more about what you're working on in Chicago.
Well, it's been great. I mean, so we have with the auspices of the American Diabetes Association and the JDRF have both been involved. We've had a group of anywhere from 25 to 50 doctors, and
Wow.
not only doctors, but all sorts of healthcare professionals involved in diabetes, educators, nurses, um, registered nutritionists, and anyone who's involved in taking care of people with diabetes have been getting together from every major medical center in Chicago, and in some cases, some of the private practice groups that are well known. And what we have been talking about is making sure that the insulin is available. So we've had representatives from Lilly and Novo and some of the other companies talk about their pipeline. But then we're sharing information. What's happening at Chicago, at Rush, at Northwestern, at North Shore, at Loyola, and UIC, and what's the experience been. So we've been sharing information on people with type 2 diabetes, on the inequities. So, as we know in Chicago, there are predominant effects on people with on African American people, on Hispanic people, in some communities, various religious people. So where there has been high incidence of COVID, along with the risk factors that we're seeing. So
Sure.
by sharing that information, understanding how people are, what best practices are, some of the things that we're doing we hadn't thought of necessarily. For example, we're seeing more what's called DKA, so diabetic ketoacidosis, how best to treat that, how much insulin to give. It's really been a tremendously wonderful interaction of this large community sharing information and best practices.
I think what I love most about that is the collaboration, the comparing notes, the discussions that many times in real life we've connected with colleagues, perhaps one on one, or we've talked to someone on the phone, or a patient's been referred. But in this way, you can really get in real time what other institutions and what other practices are doing, not only at the academic medical centers, but sort of in the surrounding suburbs, which I love. It
Yeah, I
allows
mean, I
us to
think
get the word out.
absolutely. I mean, one of the, I suppose, silver linings is that people like doing this. They like to hear from each other. The knowledge of there's a new paper that comes out. we've had one of the doctors go over it, and with expertise in that particular area, which might not be available. Our trainees are on these calls, so they're also learning about the doctors and the faculty at other places. So this is not going to go away. I mean, it may not happen every week, and I don't know that that level of intensity is necessary, but somewhere between every couple of weeks and once a month, we're going to continue to do this, and I think it will make the entire diabetes community in Chicago stronger.
I think that's great. We would love to know what you had for dinner last night. I love hearing about your vegetarian meals. What did you have?
So last night, what did we have? I mean, one day blends into another, but yeah, maybe not so much vegetarian last night, but we're doing lots of grilled vegetables, and so that's always a side dish. And I think last night there was some chicken involved, so
Oh,
not
oh,
completely
whoa,
not
whoa.
completely vegetarian, but
But
certainly
healthy, but healthy.
no red meat, and when we have animal protein, it's either chicken or turkey or fish as a rule. So we try to do what we can, and we did get to walk around. One of the beautiful things living in Hyde Park is the walk. So my wife and I have been regularly going over to the what's called the Wooded Isle behind the Museum of Science and Industry. So that's barely a mile walk from here, and the just to walk around there, it's like being in the countryside. Not It's hard to imagine it's right in the middle of Chicago. There's great herons, there's all sorts of other animal wildlife, and not too crowded. So that's been a plus. Even with the lakefront closed, that part has been left open. So to take a walk after dinner when it's not raining, those are good things.
I think it's great. I think people always love to hear about how you're doing. Maybe we'll have an entire segment around where did Lou go today? What did he have for dinner? I mean, maybe you should just start taking pictures of your dinners and we'll post them on Insta. So talk
Wonderful.
to
We'll
Lynn
do
about
that.
that.
Yeah, I mean, everything is suitable for framing, so maybe that's not
Great.
a problem.
That's great. All the clinical research information you shared today, Dr. Philipson, we will, of course, share on Facebook. We'll make sure people understand and know how to reach out to us if they are interested. And we hope folks still are interested. You're making such a difference when you participate in a clinical research study. You're really helping us understand more about diabetes care and management, but also helping us understand how we can better take care of other people down the road. So we want to encourage folks to continue to connect with us. And if you have questions, Dr. Philipson and I are always here for you. And we hope to see you again, Dr. Philipson, for part 3, right? It could be a rocky series, right? We could get up to 6 or 7, but it
Um,
won't get weird toward the end. It'll only get better.
we'll keep going.
Okay, take care. Thanks
All
again,
right,
Dr.
thank
Lou.
you.
We'll see you
All right,
soon.
well,
Bye
okay,
bye.
everybody. Bye.